Hi, my name is Nicole Ammon, and today I'm going to talk about integrated care for persons with first episode psychosis. And specifically, we're going to talk about one of the facets of integrated healthcare, sexual and reproductive health. So I don't want to start bleak. I guess I kind of am, but we won't stay here for long. April is Sexual Assault Awareness Month, and persons diagnosed with serious mental illness experience an elevated risk of sexual assault and exposure to intimate partner violence. So that's all of the participants that you are working with. And it's something that we should be aware of. That's in addition to a variety of other sexual health disparities that we see among this population. So let's face it, we don't talk about sexual health necessarily in, quote unquote, polite company, but sex and sexual health is a major part of nearly every human life at some point. Good sexual health is a basic human right. The World Health Organization defines sexual health as a state of physical, emotional, and mental and social well-being in relation to sexuality. It is not merely the absence of disease or dysfunction or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences that are free of coercion, discrimination, or violence. Research shows us that individuals with serious mental illness, such as psychosis, have lower rates of being in long-term romantic relationships, including but not limited to marriage, and lower rates of sexual activity within the last 3 months when surveyed. That said, they're like all human beings. Normal sexual development for your FEP participants includes periods of ambiguity, exploration, and changing needs over time. So some of the disparities. In addition to being at elevated risk of assault or intimate partner violence, persons with serious mental illness tend to have statistically higher rates of sexually transmitted infections, higher risk sexual behaviors such as unplanned sex, unprotected sex, having multiple partners, and they have higher rates of unplanned pregnancy, recurrent miscarriage, and rates of abortion. Persons with serious mental illness are also less likely to engage in routine sexual and reproductive health services, including accessing prophylactic contraception. They're much more likely to access emergency contraception instead. And in addition to the things noted on the last slides, the result of this, of a less access to care, which can include an array of gynecological diseases, some of which can impact fertility. Why do these disparities exist? Well, in addition to, again, the disproportionate rates of violence and victimization, probably the most talked about reason for some of these disparities is the side effect of medications. This is at least one thing that our prescribing and nurse providers might more commonly ask about. Medications can cause more than just sexual side effects. They can actually impact reproductive health. Examples noted in the literature include infertility, which persons with serious mental illness statistically experience at higher rates, a detrimental impact on the fetus if a participant is taking medication during pregnancy. And please don't ask me to elaborate on these medication concerns. I am a counselor and will happily defer those questions to physician, NP, or pharmacist. Other potential causes of the disparities are comorbid health and lifestyle factors, such as smoking, substance use, obesity, your standard social determinants of health. Health literacy can impact sexual and reproductive health, and participants might have a poor perception or awareness of their overall risk for various disparities. Interestingly, when it comes to engagement in higher risk sexual behaviors, there's a correlation between those behaviors and poorly rated quality of life and more fatalistic views of the future. So when you've got folks expressing a lower quality of life or fatalistic views, it's important to note these individuals might be at a higher risk of engaging in some high risk sexual practices. So given this, would you say that we are, or are you, discussing sexual and reproductive health with your participants? Not typically. So we kind of need to, because it's an important part of everybody's lives, and without engaging individuals in these conversations and without finding a way to do so in a way that they feel supported and comfortable, it can lead to a disconnection from our clients and our participants and misunderstanding about their concerns. So how to start? You have to start by assessing your own comfort and biases. Religion, society, culture all influence our views around sexual health, reproductive health, and sexuality, and identifying what biases you are bringing to the table so that you can, challenge them, work through them, or at least figure out how to not bring them into not bring judgment to conversations with your participants. You want to set the tone by creating a comfortable environment, establishing rapport before getting into sensitive topics, creating an environment that's trauma informed. So recognizing that many individuals have experienced trauma. We might have a person that we're working with that has experienced trauma, and we might not know what the trauma is or be aware of all of it. Just to be aware that trauma has many personal and societal consequences, anticipating how trauma survivors might respond to our words and our actions, and trying to do our part to create a space that doesn't cause further harm. Another way to set the tone and create a good environment is to create a sex positive environment. So sex positivity is just an attitude about sex, gender, and sexuality that's free of judgment and supportive of open expression. So being sex positive doesn't mean you're promoting or discouraging sexual activity. It's really just about re-educating yourself and being open to diverse points of view. Being sex positive is about accepting yourself and all of the other different identities that are out there. Our brain is our biggest sex organ. So when we talk about a sex positive culture, it includes our emotions, our identity, our relationships. The flip side of this is something we see probably far too often in our society: sex negativity. Sex negativity limits our ability to foster an inclusive environment where everyone can freely express their sexual and gender orientations without fear or judgment. Examples are pretty pervasive in American culture, at least from my point of view. And these sex negativity can be damaging to a person's self-esteem. They can make them feel depressed or guilty for not being a certain way, or for being a certain way, or for thinking certain things regarding sexual matters. Some examples of sex negative messaging or behaviors would include abstinence only, sex education, a heavy focus on religious or moral kind of overtones or messaging, any kind of shame, assuming that there's a wrongness or rightness to certain types of sex or sexuality or gender identification, or referring to things in a very heterosexual cisgender space as like being normal or natural, which inherently implies that everything else is abnormal. Anytime that you're making an inappropriate or derogatory joke, declining to use a person's chosen name or chosen pronouns is an example of sex negativity. And a big one for our space is assuming that the participants you work with are asexual. And this is a kind of a weirdly common misconception that people with serious mental illness aren't thinking about or engaged in sex in some fashion. Most humans are sexual beings, and this presents itself differently across the lifespan. Neglecting that and neglecting the centrality and diversity of an individual's sexual identity, sexual life, can lead to a huge disconnection. So next step would be taking a sex positive health history. We might not need all of the pieces of this information depending on what our particular role is with individuals, but understanding how to engage in this conversation, how to take a health history, is really important for all of us, even if we're not necessarily the one doing it with the individual participants. A sex positive health history is founded in the philosophy that consensual expressions of sexuality are healthy. It strips away the belief that some types of sex are more or less acceptable than others. Being sex positive affirms a person's right to enjoy the kind of sex that they're having without feeling judged. And it requires us to, have a comprehensive education, maybe deliver some education, particularly around sexual practices, pregnancy, family building, STIs, and, potential risks. So start by gathering basic information. So things like their preferred name, their preferred pronouns. Use the pronouns that they give you and support their gender identity in the way that they express that. What is their sexual orientation? Asking about gender identity, so asking potentially about sex assigned at birth versus current gender identity, always giving the option of other or declining to answer. Make sure to use inclusive, neutral terms and ensure a common understanding of terms. So saying things like partner instead of husband or wife or boyfriend or girlfriend, saying partner. Transition into sensitive questions. Ask if it's okay to start asking sensitive questions about sexual health history, explaining that sexual health is an important aspect of overall health. Ask what their concerns are about sexual health and pose your questions in a non-judgmental manner. Avoid assumptions based on the participant's age, appearance, or marital status. Avoid assumptions about their gender identity, sexual orientation, or practices. Prepare to be surprised. Rephrase your questions or briefly explain why you're asking a particular question. And if the participant seems kind of reluctant or uncomfortable, try to not react overtly, even if you are uncomfortable or if you feel kind of embarrassed, really paying attention to your body language and posture. So the CDC's 5Ps approach to taking a sex positive sexual history are asking about partners. So are you currently having sex of any kind with anyone? Have you ever? In recent months, how many partners have you had? Without judgment, if it's more than one. What are the gender of the partners? Do you or your partner have any other partners? Which is important just to get a bigger picture understanding of what kinds of potential risks the participant is at. You're just getting that bigger picture and letting them know this isn't about judgment. We don't care how many partners they or their partners have. It's just to really understand the holistic health aspect. What are some of the practices? Specific acts themselves might be more for the physician nurse team members, but it's important to understand some aspects of the practices the person engages in to assess the risks that they're at. So some questions that might be more applicable to therapists, case managers, supported education, employment folks, be like, how do you meet partners? Do you meet online? Do you use apps? Are you meeting in person? Have you ever exchanged sex for some type of a need with money, housing, whatever? Where are they having sex? A location can tell you a lot about potential risk factors. Protection. Do you discuss STIs, pregnancy prevention? Are you using methods? What methods are you using? If they say sometimes, well, when are the times that you're using versus not? And with whom are you using or not? How do they stay safe? And this includes things like when you're meeting a new person and you're dating somebody that's kind of newer, less known. Does somebody else know where you're going? Have you shared your location, who you're going to be with? Does somebody just know where you're going to be? Sometimes that could be really huge when meeting new people. And when they're engaged in sexual activity, how do they stay safe? Both from pregnancy, STIs, potential violence. Reinforce positive safety and safe sex practices. If they're engaged in higher risk practices, explore kind of risk harm reduction alternatives and techniques. Rather than making people feel like they shouldn't be doing something, like how do we just stay a little bit safer? Exploring past history. Have they been tested for STIs? Would they like to be? Have their partners been tested for STIs? Would they like to talk about how to encourage their partner to be tested? Are they aware of PrEP? Do they have a history of sexual trauma? Do they have a history of pregnancy? And finally, pregnancy intention. So do they want to have kids? Do they want to have more kids? When do they think that might be? How important is it to get pregnant or to prevent pregnancy? And again, kind of back to that protection, what are they or their partner doing to prevent pregnancy currently? Do they want to talk to somebody or access additional resources about this? And do they need more information, things like birth control or connection to a particular type of provider for specific areas of need? And overall, we want to foster a sense of hope, normalize their worries, be able to provide accessible information and education about sexual health, pregnancy, reproductive health to help our participants make more empowered decisions. Being in an intimate relationship and becoming a parent can be a strong motivator for some individuals for recovery. And these are kind of valued roles socially that can provide a huge buffer against some of the detrimental effects of self-stigma. So we want to do anything that we can to provide information, education, and support the development of their coping skills, potentially engage in some social skills training for those that are entering the world of parenting. If there are parenting classes that they could be connected to, and maybe even peer-delivered interventions. And as always, when appropriate, we want to engage families. When I say families, I really mean key support people, chosen families, loved ones, friends, however the participant defines family. Family, kind of broadly, involvement and their support is really important for many people, and their support can be really beneficial in promoting safe sex practices, sexual health, positivity practices, and risk reduction interventions. And I wanted to leave you with a handful of resources. So the first one is sex positive sexual health resources from sex positive families. And they have a huge litany of resources. They have resources for pretty much every age and developmental stage and on every topic. So use the link for yourself and your own education, and then pass the link to the participants you're working with. There's lots of potential little bits of learning there. So very good resource. And then around specifically sexuality education, there's two resources, one from UNESCO and then one from the Sexuality Information and Education Council of the United States, which I think kind of goes by a little cute name on their website, which is Sex Ed for Social Change. So that's the end of this, and thanks for taking the time.